Welcome to Cardiovascular Innovations Foundation. I'm going to take a couple of seconds while folks are getting logged in before I get started. Tonight, we're going to be discussing techniques to cross iliac, femoropopliteal, and BTK CTOs. So it's going to be a very technical presentation and discussion. Just want to give folks at least a minute to get a chance to log in before I move forward and introduce our esteemed colleagues and panelists and presenters. I'm Mehdi Shishabor. I'm one of the co-founders of Cardiovascular Innovations. I'm joined here by my co-founder, Dr. Subhash Banerjee, Chief of Cardiology and Director of the Cath Lab at the VA North Texas Health System in Dallas, Texas. I'm really honored to have a number of my friends and colleagues join us tonight. Dr. Matthew Bunty, Director of Vascular Medicine from St. Luke's Mid-America Heart Institute, joining us tonight. Dr. June Lee, interventional cardiologist from University Hospitals here in Cleveland, Ohio, and my partner, Dr. Peter Sokas, Director of Vascular Medicine and Interventional Peripheral Vascular Lab at Brown Medical School, has joined us, and Dr. Sherling Tsai, who is a vascular surgeon and physician at University of Texas Southwestern Medical Center and the VA Medical Center, and his partner with Dr. Subhash Banerjee is also with us. So really excited and welcome everyone tonight. I think we're gonna have a good time and have good discussion around the agenda that we have put together. I'm not gonna go through the agenda because it's gonna be a duplicate, but we're gonna be basically discussing CTOs from stem to stern kind of a thing, from the aorta all the way to the foot. So very exciting. These are the CME information. Remember that you can get your CME credit by logging in to the link that I'm going to provide for you and get your CME credit for this hour of discussion. We're thankful commercially to the folks that have, and the companies that have supported this CME program, Abbott Vascular, Boston Scientific, and Medtronic, and we are grateful for their contribution and support of CVI and these programs, these educational programs that allow us to bring folks, as I have just introduced to you, together. To get your credits, please log in to the website that I have highlighted here. This link is also, you can find it on our website, cvinnovations.org, and complete the evaluation and get your credit as I have shown you here. I'm leaving this a little bit longer for those that want to take a picture of it or copy it or save it for a second. A couple announcements, quick announcements. Please do not forget our next live CME webinar, Hemodynamic Support for PCI, When and How. It's going to be led by Dr. Manos Berlakis, our partner. It's going to be on Thursday, February 17th, again from 9 p.m. Eastern Time to 10 p.m. And then importantly, I want to highlight and please remind you to register, to get involved, to submit cases, to use the bridge grants. There are a number of opportunities for young investigators, for young fellows and early careers to be able to join CVI through various grant mechanisms that we have, including case competition, the bridge grant, our in-person, and we are really hoping it's going to happen this year. It's going to be probably one of the first meetings that is truly in person with everybody attending from July 21st to 23rd at the Hyatt Regency in Colorado, where we have held CVI for the past few years, 4 or 5 years. And lastly, remember that all of these webinars are located on our website. I mentioned it earlier, cvinnovations.org. Please join the website, download any of the previous webinars, including this one. And I hope that it can be a free informational, technical learning tool for all of you that have joined us tonight and those that haven't joined and can hear this message in the future. So with that, I'm going to start. And the first presentation, our first presentation is Dr. Peter Sokas. He's going to be discussing CTO crossing, a step-by-step approach to the iliac CTO lesions with a case presentation. Thank you, Peter, for joining. And I'm going to stop sharing and hand this to you.
Excellent. Thank you very much, Mehdi, for that a kind introduction and for the honor and privilege to be with you this evening. I'm Peter Soukas, coming to you from my hometown of Providence, Rhode Island, where I'm the Director of Vascular Medicine and the Brown Vascular and Endovascular Medicine Fellowship Program. These are my disclosures. So in starting off, when we're talking about iliac CTO, access is obviously one of the primary determinants of success and probably the first primary decision that you need to make is, where am I going to approach this CTO from? Obviously, if a patient has had prior CTO cap morphology imaging by either prior angiography or perhaps a prior CTA, that's very helpful. You know, knowing where the beak is can be very helpful. You want to, in general, be going in the same direction as that beak. You're more likely to stay intraluminal that way. But in general, having said that, proximal common iliac CTOs are typically approached from an antigrade brachial or radial approach, whereas external iliac CTOs, by and large, can be approached from a contralateral up and over access, unless, of course, the patient has had a prior aortic bifem, EVAR, or kissing stents that extend into the aortic bifurcation, or in the case of severe iliac tortuosity. In general, but particularly when dealing with CTOs, I always recommend ultrasound-guided access with a micropuncture kit. What about radial access for CTOs? Well, the advantages, of course, are that there are less vascular complications. You can avoid a disease, common femoral, and patients love it because they can get out of bed earlier, and hemostasis is a breeze for the team. The disadvantages, of course, are that you're, for most patients, limited to a 6 French sheath size, and radial arteries, especially when you're putting in long sheaths, are more prone to spasm and tortuosity. If it's a very tall person's possibility, you might not reach your target lesion. And unfortunately, there are limited equipment lengths and treatment options available when you're treating PAD patients from the wrist. And I always advocate for 7 French sheaths in the event that you need a covered stent, in case that you have a perforation. So in general, the TAS2 guidelines pretty much recommend endovascular methods for almost all iliac lesions. Most TAS-D lesions can be treated by endovascular means. A good thought to keep in mind is that if a patient has severe calcification, they are at greater risk for vessel rupture, and you may want to think about using stent grafts pretty much right out of the gate in that particular circumstance. Here's an example of a calcified aortic bifurcation, and after bilateral stents are deployed, you can see right where that big chunk of calcium was. Of course, that patient ended up developing a perforation. And we know that iliac perforations are potentially life-threatening events, so it's critically important to have all of your rescue equipment and to have 7 French sheaths so that you can move quickly to avoid a catastrophe. So iliac CTO equipment musts. Obviously, as that last image just hopefully burned into your brain, you need to have balloon expandable and self-expanding covered stents immediately available, not in a back room somewhere. You should also have aortic occlusion balloons. Merit has a Q50 balloon, which is 10 French sheath compatible. The Cto balloons are 12 French compatible from Cook. We tend to use CTO devices such as the Wingman, the Go Back, and the Crosser selectively. And occasionally you may need a reentry device like a Pioneer, an Outback, or an Off-Road to help get you back into the true lumen. So let's, with that by way of introduction, jump in and look at some fun cases here. So these are all recent cases that we did. This is a 55-year-old diabetic smoker who had a right leg DVT back in the throes of COVID. He was afraid to come to the hospital, didn't even get any coagulation. He presented with post-thrombotic syndrome. And everyone was talking about his poor leg after his DVT, but we noticed that his symptoms sure sounded like claudication, and he had no really good distal pedal pulses. So we did a CTA, which confirmed, lo and behold, he had occlusions of his right common and external iliac arteries, as well as a 75% external iliac artery stenosis. So in this particular case, we employed a left brachial access, and you can see that there's a stump there in the right common iliac with diffuse left common and external iliac disease. There's reconstitution here of the common femoral at the top of the femoral head. And we went ahead and treated the iliac disease first on the left, and then used a wingman device. This is a crossing device made by Reflow Medical, which we found to be very helpful. And we were able to deliver a wire through that occlusion relatively quickly and confirmed that we were in the true lumen with a selective angiogram here, and then PTA with small balloons, because if you're subintimal, you don't want to take a big balloon and get a rupture. So small balloons to make sure you don't have a perforation. Went ahead and stented the external iliac, lined up a common iliac balloon expandable stent, deployed that. But we noticed that there was still this lesion here. This actually was a calcified plaque that really extended from the aorta into the ostium of the common iliac. And we measured a gradient across that. And lo and behold, there was a 20 mm gradient. So we obtained ultrasound-guided micropuncture right common femoral access. And then it was a matter of simply just lining up those two stents, doing simultaneous kissing stents, stented the common. And you can see our final angiogram, really a lovely result, and that patient's symptoms were completely resolved. This was a 49-year-old male smoker who had had a history of premature PAD, who now had significant left hip claudication. His CTA showed common and external iliac CTOs, as well as a right common iliac stenosis. And his local vascular surgeon actually referred him to us for an attempt at endovascular revascularization. And you can see on his baseline angiograms, after we obtained left brachial access with a 7 French sheath, we have a nice stump here in the proximal common iliac artery. The common femoral does reconstitute via these collaterals from the hypogastric and sacral arteries. And in this particular case, we tried a crosser device, but we sort of got stuck and we couldn't make any forward progress. And then we tried a support catheter and some aggressive wiring. Unfortunately, that did result in a small area of extravasation. So we sort of decided that we probably should try a different approach. But the question is, how are we going to get through this if we're unsuccessful from above and the right significantly diseased without a nice crossover beak? So in this particular case, we elected to employ ultrasound-guided left SFA access, so we would have plenty of running room. And you can see selective angiography confirms that there is occlusion of the common femoral at the junction of the external iliac at the level of the inguinal ligament. And initially we used a front runner device to kind of burrow our way through there. And we got through to the proximal cap, but we noted that the device was taking sort of a more lateral direction. And so we took that out and then basically took a I believe it was an Estado wire, and we were able to then redirect that more towards the medial side of the occlusion. And then lo and behold, we were able to pop through. We then exteriorized that wire, re-delivered it in an antigrade fashion down into the SFA and distal popliteal. We then performed internal balloon hemostasis of the SFA access site. Once we confirmed we were hemostatic, we then went ahead and treated this complex aortic bifurcation with balloon angioplasty of the iliacs and external iliac stenting bilaterally, lined up the left common iliac, stented the right, and then for the bifurcation, we elected to treat that with a so-called top hat and trousers approach, where we place an aortic stent in the distal abdominal aorta after upsizing to an 8 French sheath on the right. This was a 10/29 VBX covered stent. After post-dilating the stent, we then went ahead and put in the trousers, which were 2 8 mm VBX stents. And you can see here a really lovely result here at the end. Our third case, another male smoker with 50-yard claudication, was found to have an aortic occlusion. Both we and the vascular surgeon who referred him both suggested an aorta bifemoral, but he refused because he was afraid he would lose his job. And so we brought him in for an attempt at endovascular reconstruction. And we obtained triple access, both common femorals, retrograde, as well as a left brachial access. And you can see a pretty extensive degree of occlusive disease in the distal abdominal aorta and both common iliac arteries. We initially approached the left occlusion using a wingman. We're able to then deliver a glide wire. A 5 French vertebral catheter was then extended into the true lumen distally, and then that wire was exteriorized and externalized right through that vertebral diagnostic catheter, confirmed that we're in the true lumen, and then proceeded with low pressure balloon angioplasty. And after confirming that we had restoration of antegrade flow without any perforation, we then moved on to the right common iliac. And initially, you know, we had a little bit of a beak there. So we thought, well, gee, maybe we could just loop a glide wire through here and get retrograde. Unfortunately, that was not the case, as you can see here, that we were subintimal. So in this particular case, we elected to bring that vert back down there, and then we're able to cross with an Estado 30, got that wire past the sheath into the true lumen of the common femoral. And as you can see here in real time, the movie basically just showing how we exteriorized that antegrade wire through that diagnostic catheter, proceeded with balloon angioplasty, long balloons, followed by another top hat and trousers, and self-expanding stents for the external iliacs after redirecting the right wire through the aortic stent lumen. Post-dilated the aorta with a 14-millimeter balloon after Ibis demonstrated that was the actual diameter of the distal abdominal aorta. And then, of course, proceeded with our top hat and trousers here. These were a couple of 7x59 balloon expandable stents. And then after stenting the externals, we post-dilated all the stents with 8-millimeter balloons and ended up with really a very nice result here. And this patient was completely rendered asymptomatic. My last case is a morbidly obese diabetic female with COPD, obstructive sleep apnea, who had had a prior DVT and PE, who now presented with multiple ulcers of the right foot in multiple distributions, as you can see here. Her angiogram showed that she had calcified flush, essentially flush right common iliac occlusion with severe calcified bilateral iliacs. So we obtained retrograde common femoral access. You can see that extensive calcification. We're able to pop through because we had a nice beak there on the right. Then proceeded with intravascular lithotripsy with 7-millimeter shockwave balloons, used some more on the left. And after preparing both calcified iliacs with intravascular lithotripsy, then proceeded with a couple of VBX kissing stents, as well as some external iliac stents with really a lovely final result. So in summary, as you see here, I always start with ultrasound guided access with a micropuncture kit. And in general, we'll approach proximal common iliac CTOs from the antegrade approach, the external CTOs from an up and over approach. But as I showed on that last case, it's perfectly okay to go retrograde, especially if you're in the same direction as the CTO beak. We utilize CTO devices in reentry catheters as necessary. We don't use them on every single case. And we've now really become standard of care in our lab to use intravascular lithotripsy for these calcified lesions, and have a very strong preference for using stent graft for calcified occlusive lesions to avoid the risk of life-threatening perforation. Because that is always a very real possibility when dealing with iliac CTOs, you must have 7 French sheaths so that you can deal with that problem immediately. And we have a little box that we call our Aortic Emergency Kit. And it's got a Q50 aortic occlusion balloon, coda balloons, and a full complement of balloon expandable and self-expanding covered stents. And with that, I will yield my time and thank you for your attention.
Peter, thank you for that wonderful, fast-moving case presentation. You have got us all warmed up, and I think we don't have much time for discussion. I just want to ask you one question, because you demonstrated a variety of advanced and preliminary skills. Answer 2 questions. When you approach a CTO from the common femoral or from the radial, is it standard for use to start with an 035 or an 018 supported, 014 or 018 supported guide wire?
Yeah, I'd have to say most of the time I just go directly to an 035 for these CTOs. Not uncommonly, as you saw in that last case in particular, these are pretty densely calcified, and you need something that's going to give you adequate backup and support. So I'll typically for iliacs use 035. Now, for femoropopliteal lesions, I usually will then sort of downgrade that to an 018 system, and then below the knee, I typically use an 014. So a lot of it depends on the degree of calcification and the size and diameter of the vessels in terms of which particular technologies I'm going to use as far as wire diameters are concerned.
Thank you. Second question, very briefly, even though you cross into the common femoral sheath, say from radial, do you rely generally on your field angiographic appearance, or you actually proactively do intravascular ultrasound to really get to know the course of the vessel because of the guide wire, because that can be sometimes not so easy to discern? Your comments?
Yeah, so in general, we typically don't need to routinely use intravascular ultrasound imaging as far as the crossing part of it is concerned. However, I use it very, very liberally for when I'm sizing my stents, particularly in occlusions and particularly for the aorta. You definitely don't want to be too big and risk rupture. But on the other hand, you don't want to be too small, because as you well know, if you pick a stent that's too small and you post-dilate it with a big balloon, you're going to get significant foreshortening. And that's obviously undesirable. So I'm a very big proponent of Ibis for stent sizing.
Thank you, Peter. We'll leave the rest of the provocative questions to Mehdi. Let's quickly get on to the role of femoropopliteal and BTK CTO algorithms from Matt Bunty, or the lack of it. So let me put that out and invite Matt to take it over. Matt, you're on, buddy.
Great, thanks, Subhash, and thanks for the invitation to present tonight. So I'm going to talk about FemPop and below the knee, so all the infrainguinal CTO, and this will be more of a structural algorithmic discussion about these lesions. Some of my disclosures. Peripheral artery CTOs are a growing challenge and now represent about half of all CLI and claudican cases we treat. And the lesion complexity can really limit endovascular treatment success, especially when the endovascular treatment that are available are limited. Peripheral CTO treatment failure can be as high as 30% in some reports, and inefficient crossing and inability to cross can lead to frustration and sometimes short-sightedness that begets complications. So really, to treat these lesions, we need a strategy that has a good understanding of the equipment as well as lesion morphology, and uses skill and strategy to have success. In-hospital adverse events associated with peripheral CTOs following revascularization are common and occur in both surgical and endovascular treatment groups, and include vascular complications as well as major bleeding and acute kidney injury. And this is related to a myriad of anatomic challenges with both femoropopliteal as well as below the knee occlusions, including long or serially occluded segments, proximal or distal cap ambiguity, calcification, and limited runoff. So in order to satisfy our ability to get through these lesions, we can apply attribution theory, which is really concerned with how ordinary people explain the causes of behavior and events. And hopefully we can take these peripheral CTOs away from the luck category and more to the ability category, where things are more stable and controlled. And with this talk and some of the references we'll show here, hopefully that's possible. And I think it really starts with applying a systematic approach to understanding how the case starts, what the lesion is like, and then how you're going to fix it. And so starting with lesion morphology, we can understand well the CTO cap length and morphology, which tends to guide treatment approach, as well as antigrade and retrograde crossing options. As was pointed out in the last discussion, there are sometimes cases with a bifurcated stent grafts that limit access options for crossover techniques. So radial access can be important in those circumstances, for example. Crossing devices are certainly an important treatment strategy to use, although antegrade dissection reentry remains my go-to in most cases. And treatment strategy, and whether you're going to stent or angioplasty, use atherectomy or other devices to treat calcification, can be important in deciding how to approach a CTO. The role of these algorithms, of course, then are to improve procedural success, which can be achieved by understanding advances in equipment and technique. Common principles applied to practice can enhance that efficiency despite complex anatomy, and commitment to these principles I have found engender success with acceptably low complication rates. And really, the first stab at kind of being systematic about peripheral CTO crossing probably started with this publication back in 2018, looking primarily at CTO cap morphology, although there were some limitations with this algorithm, in my opinion. And I think while lesion length and crossing strategy certainly are important, there was a little more sophistication probably due. So that was done with this peripheral CTO classification and crossing strategy. This was an excellent framework developed from the expertise of 11 high-volume peripheral CTO operators, and was supported by literature findings and registry reports to develop these best practice recommendations. There are really three key aspects to this crossing strategy, including the proximal cap, whether there are suboptimal distal targets, and then the length of the lesion to really guide whether lesions are approached well antegrade or retrograde, or using a hybrid approach. So we'll go into some of this in a little more detail. And really, with an antegrade crossing strategy, what I look for, as suggested by this document, is a concave or tapered proximal CTO cap that's well visualized and has a suitable distal target for treatment, and generally are shorter CTO lengths. And so with the antegrade CTO crossing, there's really two strategies we can consider. One is antegrade wire escalation, usually with a wire and catheter approach, or going straight to an antegrade dissection and reentry strategy. Note that usually if you're going to start with an antegrade dissection reentry strategy, it's really tough to go backwards and use wire escalation at that point. And I find that in my practice, antegrade wire escalation is generally my preferred technique. After, if antegrade wire escalation does fail, then we have options to re-enter, and that can be through a controlled re-entry with an Outback or Pioneer or Anterior device, or an uncontrolled re-entry using other techniques such as wire escalation, STAR, or LAST. So this is a case of an 82-year-old female with a right fifth metatarsal head ulcer and osteomyelitis, as well as a midfoot ulcer. And unfortunately, this woman was not a good surgical candidate. She had just had a heart attack, was in the hospital with heart failure after she completely destroyed her right hip in a fall. You can see the nail in her right femur that kind of obscures some of the imaging here, but there is a fairly long and complex CTO, although it seems to reconstitute not too far into the probably the mid SFA. And I think on the second panel there, you can see that there are multiple serial lesions within the distal SFA into the popliteal segment, but seems to reconstitute nicely in the P3 segment and below the knee with good runoff to the foot. So I decided, because this was a fairly, although heavily calcified, a reasonably short proximal CTO with a favorable cap, to start with a 7 French crossover in an antegrade approach with a Navicross microcatheter and a hydrophilic wire. I was able to progress through the lesion to a certain point, and then used a more controlled drilling technique with a beefier 018 Treasure 12 wire. But serial focal calcification required me to change out supports for a balloon catheter to kind of progressively dilate and daughter through the lesion. And eventually I wasn't able to proceed much further, and ended up using rotational atherectomy and intravascular lithotripsy to complete the procedure. But at the end of it, you can see that we had a reasonably good endovascular result given the circumstances for the patient, and she went on to heal after several weeks. So in this case, despite the complexities of the calcification and needing atherectomy, we were able to successfully complete the procedure just simply with antegrade wire escalation. Although certainly she came to the lab with the foot prepped and other options available. So let's move into retrograde CTO crossing strategy. I typically reserve this for more convex or ambiguous proximal caps, concave distal caps, or or when there is a good available distal access. And I particularly like this technique for long CTOs. And again, just like antegrade crossing, there's two primary retrograde crossing strategies, again with retrograde wire escalation or that dissection reentry, which can be either controlled or uncontrolled. And so this is a 79-year-old gentleman with a left leg claudication, which is lifestyle limiting, and a fairly long CTO from the mid SFA into the popliteal segment. Sorry, I kind of skipped over that. Let me go back. You can see the CTO does extend down into the popliteal, and it becomes very ambiguous, although there is some distal reconstitution and reasonable targets for retrograde access, particularly in the posterior tibial artery, which is indeed what we use. So in the first frame here, you can see my microcatheter extending into a very heavily calcified portion of this lesion at the adductor canal. And so I used a retrograde approach with a knuckled microcatheter and wire, hydrophilic wire, to shorten the CTO length effectively, and then was able to use a microcatheter rendezvous technique to basically wire the retrograde wire into the proximal balloon catheter and externalize the wire, and then I had sufficient support to complete the intervention. And this was our final result. Just a comment about whether you use crossing devices or wire catheter approach, the duration, fluid time, and contrast volume all seem to be fairly similar. So I think it's somewhat a matter of preference and consistency in using these techniques. They both offer good results. Just a comment about below the knee kind of exclusive crossing strategy. In my practice, I adapt similar principles of retrograde support for ambiguous caps, long lesions, and calcification. I use intravascular imaging to properly locate and size treatment zones, especially when calcification can make that hard to judge angiographically. I use vasodilators liberally and limit atherectomy and CLTI to maintain distal microcirculation and try to effectively shorten that peripheral CTO distance, as in the last case, as much as possible to facilitate crossing. And I rely more on wire and catheter support with selective microcatheter injections or dual angiography to cross these lesions. And I think it's important to point out that in our CLTI population, most of those folks are going to have a degree of tibial and pedal artery disease, but really multi-level disease is what describes that group. So I'm not going to belabor this table, but just to suggest that there are a number of polymer jacketed and non-jacketed 014, 018 wires and polymer jacketed 035 wires that are routinely used for successful wire and catheter crossing. And I think these slides will be available if you want to review this further. Similarly, the support catheters are, there's a number of support catheters used. I'll just point out that the braided hydrophilic catheters tend to, in my practice, be the more effective options. And then I've also come to appreciate the 200 centimeter Viper cath, which is a long microcatheter that can be helpful for radial interventions. So to summarize, we have this percutaneous crossing algorithm for femoropopliteal and tibial artery CTOs, and we kind of broke it down into antegrade and retrograde, but really this flows nicely depending on cap morphology, lesion length, and the suitability of distal targets. And I think going through this algorithm systematically will help to facilitate effective and efficient crossing. So to summarize, understanding peripheral CTO lesion characteristics to guide approach and understanding equipment before starting the case is really critical. Proximal cap morphology, lesion length, and distal popliteal CTO location tend to predict the need for retrograde support. Prepare for and use consistent crossing algorithms for safe, efficient, and consistent crossing. With that, I'll turn it back over.
Matt, thank you so much. Wonderful presentation and very thorough. A lot of tips and tricks, a lot of equipment, and all of that will be available. Obviously, a lot of fast-paced discussion, and we don't need to know obviously every equipment. You need to be mastering one or two of them, as you highlighted. My question to you was that I like this plaque, kind of a cap morphology is very nice, but I have never, honestly, it's been very difficult for me to actually use it in clinical practice, meaning that I normally, I approach it from antigrade. If I get stuck, I don't waste too much time like I used to, and I go quickly retrograde and then try to find the middle ground. I'm just interested to know how often is it you do the diagnostic angiogram and you're like, oh, this is convex. I'm not going to go even try from the top. I'm going to go retrograde and try from the bottom because this is convex. I want some honest answers tonight.
Well, I happen to be trained by a pretty good guy, and I tend to follow his similar approach where, generally speaking, no matter the cap, I feel like an antigrade attempt is reasonable. It sometimes can be really challenging if there is a really convex cap with a lot of collaterals that come off that just kind of make it impossible to enter the CTO. But outside of that, admittedly, I don't tend to necessarily shy away from an antigrade attempt, although I too and my lab staff will tell you that every case comes to the lab with the foot prepped and ready to go, and we have a very low threshold to use retrograde access to complete the procedure.
That's great. And then one other question I had, and maybe in preparation for the next presentation, when do you stop? When do you, is there a time to say, you know what, I've tried antigrade, I've tried retrograde. Is there a time limit? Is it your back? Is it your neck? When do you say, you know what, maybe I bring this patient back? Is there such a time? Or any thoughts on that?
Well, the guy I trained with didn't stop, so we stayed there all night, and yeah.
I think you to speak your mind and not be coerced.
No, my lab staff will tell you that we don't give up easy, and yeah, you have to know when to say when, and first, do no harm, please. I mean, if things aren't going well and multiple things are not working out, come back to fight another day. I think that's one of the things I've learned and reinforced in practice. But sometimes these lesions are not for the faint of heart, and unless you really are willing to stick it out, I mean, you're not going to have success in some of these things. So you got to have a strategy, and you got to have kind of the next 2 or 3 steps in your head. And when you run out of those, that's probably the time to stop.
Okay, well, wonderful, man. Matt, thank you so much. You give me too much credit, man. I really appreciate you, and thank you so much. Let's move on to the next presentation. I have some other questions for the discussion if you have time, that we can discuss. I'd like to move to wire. There were a couple of questions in the chat about wire escalation, and Matt mentioned some of those, but I think that we're going to get more detailed kind of a presentation about wire escalation, CTO crossing, and reentry devices by Dr. Sherling Said. Thank you, Sherling.
Hi, good evening. Thank you for inviting me to this. I'm going to talk a little bit about wire escalation and some CTO crossing devices and reentry devices. I'm not sure why they are not advanced. Oh, there we go. Okay. So as we know from the XLPAD registry, CTOs can be approached in 2 general categories, either with a wire catheter approach or a crossing device. And based on the XLPAD registry, the majority of us would start with an initial attempt with a wire catheter approach, 82% of cases. So if we're going down the road of a wire catheter, there's generally some algorithm, so some idea in your head about how you're going to go along doing this. And despite the fact that this looks like a linear algorithm, really the thought process is not really linear, because although you may start with a guide wire and catheter, oftentimes you do end up resorting to using a crossing device. And if you start with a crossing device, you may end up with a guide wire and catheter. And regardless of what you start with, you may well need a reentry device, or you may need to get retrograde access. So just like Matt had just said, the preparation and being prepared to access the foot for retrograde access is important when you're starting these cases. So if you're going to do a wire catheter approach, generally there are some principles that you want to follow. One thing that I try to do is I get as good distal sheath support as I can. So if it's going to be like an SFA occlusion, you get the sheath into the common femoral, into the proximal SFA. But if you're looking at a popliteal or tibial occlusion, then really you need a longer sheath into like the distal SFA or into the popliteal for good distal sheath support. Then if you're looking at doing a femoral popliteal CTOs, usually we start with a bigger platform, so an 035 platform. So there's a whole slew of wires and catheters that you can use. Really, it depends on personal preference and then whatever you have stocked in your lab. But generally, you start with an 035 system and something that is hydrophilic. So a glide wire, glide catheter combination. I like the glide wire Navicross combination, and I've come to like the 018 Navicross because it can be telescoped into the 035 Navicross. But basically whatever you're comfortable with would work. Then if the 035 system doesn't work, you can escalate to an 018 system. So for example, a V18 wire, which is hydrophilic tip, and then an 014 system, such as a command wire or a journey wire. Then when those options are exhausted, I usually turn to the non-polymer jacketed or the weighted wires. So the one I usually go to is the Cook approach wire or the CTO wire, which is a weighted wire. And again, it really depends on whatever you have and that you're familiar with. If you're looking at below the knee, again, it's the same idea of starting with the hydrophilic wires and then moving on to the non-hydrophilic or the non-polymer jacketed wires. Just that you wouldn't necessarily start with an 035 system. Oftentimes we'll start with an 018 or 014 system. So here's one case I did recently. This was a patient with a chronic wound of the fourth toe. And he actually had inline flow all the way to the posterior tibial at the ankle. And then he had this occlusion right at the level of the ankle. So I set this up with a 90 centimeter terumal sheath in the distal popliteal artery. And then we got a 018, a Navicross, and a V18 wire, and managed to get the V18 wire and Navicross across the occlusion. Here's our confirmation angiogram with this catheter in the just distal to the occlusion to show that the lateral tarsal artery is open. And then just a note of caution here, whatever wire you use to cross this occlusion is probably not the wire you want to work over. So even though we cross this with a V18, you don't want to be putting the V18 into this tiny little lateral tarsal artery. So I switched over to a Spartacore wire, balloon angioplasty. And even though we switched over to a more benign wire, you can see that this poor little lateral tarsal is not quite as happy as it used to be. Despite that, this patient's NIFs, the toe pressure improved from like 30 to 75, and the metatarsal waveform was much better. But it's just something to keep in mind that your crossing wire is not necessarily your working wire when you're doing your balloon angioplasty. So if you're not going down the road of guide wire and catheter, you can look at using crossing devices. And one of the nice things about the crossing device is that the idea is that you want to stay true luminal. Now, you don't necessarily always stay true luminal with the crossing device, but the idea behind them is that rather than ending up subintimal, as you often do with a guide wire and catheter, with a crossing device, you have probably a higher chance of remaining in the true lumen. And crossing devices, in my mind, can be separated into two types. And there are probably others, but these are the ones that I'm familiar with. So you have the one that has a dissecting tip, like the front runner, where it's basically a pair of forceps that micro dissects through the occlusion. So you position it at the top cap, and then you use these forceps that open and close and basically dissect or micro dissect through the occlusion. Then the other ones have some sort of rotating distal tip. So the Vions, you actually manually rotate or you spin the tip, and then the TruePath, the Crosser, and the Wildcat have some sort of motorized device that spins or dissects through this. And basically the idea there is once you get the catheter into the top cap, you just sort of drill through this occlusion. So here's an example of a SFA popliteal CTO using a Viance. So this is the initial angiogram showing it's actually a stent occlusion with an occlusion of the popliteal distal to the stent. And here we use the Viance and Confianza wires. So this is the Viance catheter with the wire inside the catheter. And the thing with the Viance is that the wire you do not necessarily lead with the wire, which is contrary to what a lot of us always think. You always lead with the wire, but with this, you lead with the catheter and you spin the catheter pretty quickly. And the idea is that you can pull the wire back to readjust the direction of the catheter. And you can see here that the catheter has just gone right through the occlusion. So we confirmed with Ibis that we were in the true lumen distal to the occlusion, and here is the completion angiogram. So that works out pretty well. It gets us through this in the true lumen crossing, but that doesn't always happen. Like even with a crossing device or with a guide wire, you can end up subintimal, and this happens more often than not. So then, you really need to think about how you're going to get back into the true lumen. And some people are good and they can do this with a wire and catheter. And I usually end up turning to reentry devices. And there's several out in the market. Here are a couple of them. The Pioneer catheter has Ibis integration. So it's very nice because you can use the Ibis to figure out where the true lumen is. You turn on the color flow and you can see where there's red flow in the true lumen. You orient that to 12 o'clock, and that means that the needle, the curved needle of the reentry device points up into the true lumen. Similarly, the Outback, you orient yourself to the true lumen by setting up two orthogonal pictures, one in the shape of an L, where the L points to the true lumen, and one in the shape of a T, where the T lies over the true lumen, and then that directs the curved needle to point into the true lumen. The downside of the Pioneer and Outback catheter is that they're relatively bulky, so it can be difficult sometimes to track this over a tortuous bifurcation, and it can be difficult to track this through a calcified artery. And then the other problem or the downside is that it's so bulky, you end up with a pretty significant space in the subintimal plane when you use these, say, reentry catheters. The anterior catheter is a little bit different. It's a lower profile system, and it basically blows up a flat balloon in the subintimal space. And when this flat balloon blows up, there's a little exit port of the catheter of the balloon, and you use the anterior wire, which is an angled wire, to poke through the side, the exit port, and into the true lumen. And in theory, this sounds like a great idea, and it actually works really well because it's such a small space. It actually doesn't cause a big dissection plane. The only downside is that the 014 wire sometimes is not sharp or stiff enough to poke through a thick intimal flap or a calcified flap. But here is an example of using the anterior catheter. So here you can see at the red arrow that the wire is clearly not in the plane of it, clearly not in the lumen. It's in the subintimal plane. So we use the anterior catheter, which is the second picture, and you can see the wire going out the exit port and then passing freely into the popliteal there, and then the completion angiogram, which not playing here it is. The completion angiogram shows that, there we go, is it playing? Well, the completion angiogram should show that it has been recanalized. So that actually works out really well. And the nice thing, as I said before about the anterior catheter, is that it really leaves a very small subintimal space, which is important because if you can't get back in with a reentry device, then I think you need to look at how to get back in from retrograde access. And if you're going to do that, it really helps to have a small subintimal space to try to meet up a retrograde catheter and antigrade catheter. So here's a schematic of doing that. So here you would see the antigrade catheter with a wire in the small subintimal space, and then a retrograde catheter. And you want these to be pretty close to each other so that when you advance the catheter from the retrograde catheter into the antigrade catheter, there's nowhere else for that wire to go except for into the other catheter. So here's an example. So we have two wires, the antigrade wire and the retrograde wire, clearly not in the same plane. So we changed out on the antigrade side into an 035 Navicross catheter. And then from retrograde, we advanced a wire and catheter and directed it into, basically cannulated the antigrade catheter. And that the only way to do that really is to keep a very small subintimal dissection plane. So I think that is the last slide. Any questions?
Shirling, thank you very much. I think you, I know you up close and personal, so I know you are a fan of minor details, and I'm not going to belabor it because Mehdi Shishibur is taking extensive notes from the pointers you gave. But I think one point that came out loud and clear is that you are, and knowing you, that you don't try to mess around too much. Even when you are just outside the subintimal plane, you quickly move to reentry rather than trying multiple wire manipulations that can extend the dissection plane. I think that is one of the important teaching points, and I do believe that that not only facilitates the use of re-entry device in an antigrade fashion, but also get retrograde access and confirm and perform the rendezvous procedures. I want to ask you one provocative question that I've asked you and not been able to change you yet. You still start with an 035 wire, and many of us do start with a 018 system, maybe a command, and then move on to a stato and quickly escalate. And you use the word very precisely that you escalate from an 03 wire to an 018 and then to an stato. I mean, explain. That was of course, a provocative question to you. So why do you call it escalation? Why do you still start with 035? Do you think it's time to change?
I think, good question. I actually don't always start with an 035. I think for the purposes of coming up with a idea, a framework, it's nice to start, but really I start with whatever I think would work on the angiogram. So in my mind, I have always started with a glide wire glide catheter, but I think as I've learned from you over the years, sometimes it is better to just go straight to the command wire. And that would work perfectly fine. But you know, if you're sort of going to go through this systematically in some sort of an algorithm, you know, usually it's that I look at this and I think, oh, the 035 system is not going to be the best way to do it here. We should, because maybe it's very calcified, or maybe it would be, whatever the reason is, it would be better to just try a different wire to start with.
Thank you very much, Sherling. Getting a public commitment from you makes life easier at work. Let me jump over straight to Dr. June Lee. June has a very interesting topic. I can tell you that this is probably one of the toughest ones for tonight, and no one else can pull it off except for June. So June, you're going to talk about the role of intravascular imaging in CTO intervention, something that we have kind of brushed and touched, and probably will encounter more of it in the Q&A that Mehdi is going to lead. So take it away, June, and thank you for being here.
Thank you, Subhash, and thank you, Mehdi, for the invitation. These are my disclosures. So why utilize intravascular imaging? First of all, we utilize it a lot in the coronary space. We know that in the peripheral space, I think in 2022, it's time that we start applying it more and more routinely. So you can appropriately size your vessels, especially if you're doing work in the aorta or iliac, as Dr. Sukas has referred to. Understanding the composition of plaque, for example, how much calcium is inside your CTO. Do you need to do any atherectomy? Are you intraluminal? Are you subintimal? Post-intervention evaluation, for example, understanding how much lumen you've gained, the expansion of your stent and apposition of your stent. Imaging assisted crossing of CTO and reentry, and that's been touched on a little bit, including the Avenger device, which is an OCT guided crossing device, and then the Pioneer, which is a Ibis guided reentry device. And then obviously diagnostic conundrums when there's confusion about what is happening with your angiogram, that would be another appropriate use for intravascular imaging. What are our options? So intravascular ultrasound or Ibis is better for iliofemoral segments, particularly given the size of these arteries. Also, obviously, for venous interventions as well. CTOs in general, it's safer to use Ibis compared to OCT because you're, if there's questions about intraluminal crossing, you don't necessarily want to inject contrast into a subintimal space. OCT has better spatial resolution. As we know from coronary space, you can see more definition and better calcium quantification, but obviously limited by the diameter of the vessel. In general, it's actually very hard to visualize anything that's greater than or equal to 6 millimeters. So essentially anything above the popliteal, it's going to be a little bit difficult to image. So what are the benefits of Ibis in endovascular interventions? Eric Semsky published this data recently in 2021. Actually, it was presented at TCT. So he looked at the Medicare database from 2016 to 2019. Overall, there was over 697,000 interventions in the Medicare database during that time frame, with 11% use of Ibis, which is the highest increase was actually in OBLs and ASCs. Here you can see the time frame from 2016 to 2019. It has really tremendously grew in the OBLs and ASCs, but unfortunately, in the overall kind of in hospital interventions and outpatient hospital interventions, it has really been stagnant. Even within the operators that use Ibis a lot, though, there's a lot of variation in terms of how much they use it, with a median use of 5.4% only. What we noticed from this Medicare database is, though, the use of intravascular ultrasound led to a reduction in male. And male in this specific study was accounted for by endovascular or surgical revascularization, arterial thrombosis or embolism, or amputation. There was a 32% reduction in male up to 425 days. So very important outcome here. So we'll start with a first case, 69-year-old woman with diabetes, coronary disease, had a prior bypass, ischemic cardiomyopathy, EF of 35 to 40%, CKD, hypertension, dyslipidemia, CVA. So, you know, our typical peripheral patient. She had a first digit amputation on the right side previously, as well as the left TMA, both were healed. She was admitted at that time when I saw her with a non-healing right foot wound. And here you can see pretty extensive tissue involvement. Speaking with the podiatrist, this fortunately did not tunnel through completely, which is what I was worried about when I first met this patient. So we agreed to proceed with angiogram and see kind of what we're dealing with and see if we can give her a chance at limb salvage. Here you can see in the preceding ABI, TBI, the ABI is 0.44 with the toe brachial index of 0.52, which may be falsely elevated due to calcium. And here is her angiogram. The iliacs were pretty decent. The cap of the SFA is actually quite ambiguous. This is the profunda coming off the common femoral artery. And here you can see the long segment CTO with reconstitution and essentially P2 segment. There's actually a really good anterior tibial artery with a little bit of moderate blockage proximally, and the TP trunk posterior tibial and peroneal are all occluded. So which approach would you take based on Matt's algorithm? Would you go antigrade? Would you go retrograde? In my practice, this patient actually, because of the ambiguity of the proximal cap, my approach was actually to go retrograde first. So retrograde access into the AT. I apologize, these videos are a little bit fuzzy. In this patient, I actually chose to go with a 018 system first because I actually thought the plaque was pretty soft and not highly calcified. The patient who is highly calcified, I might have chosen an 035 system up front. So here you can see retrograde wise, we reached the proximal SFA. And at this point, I don't really want to exit into the common femoral through the subintimal space. So I actually engaged the proximal cap and entered with a 035 system up top. And luckily we were able to enter into the subintimal space of what I thought was the SFA. We snared a wire, externalized, did balloon angioplasty and DCB. Here you can see after our DCB, there's a dissection plane in the mid SFA, which was stented successfully. And proximally, you can also appreciate a small dissection plane here with some haziness in the common femoral artery. At this point, I decided to balloon it at high pressures to try to break that subintimal space and then ended up stenting it. But even after the stent, you can actually still see this subintimal, this little flap right here. So the question is, what is happening? So Ibis was performed. And here I'm gonna pull back a little bit fast. Here you can see the transition of the stent into the subintimal space. And here's actually the true lumen of the common femoral artery. In retrospect, I think what had actually happened in this case was my tech and I were trying to externalize with the snare, and we might have been a little bit uncoordinated, and the wire actually came off the snare as it's coming into the common femoral artery. And I believe that's actually where we lost it into a more subintimal layer as opposed to the true lumen of the common femoral. So I did more balloon angioplasty. I did a scoring balloon. I didn't have a cutting balloon available in that size in my lab. And here you can see there's decent flow integrated into the SFA as well as into the profunda. You can still kind of make out the flap there. I decided not to treat this further, and the reason is because if I end up treating it further with an additional stent, there's a high risk that I'll end up jailing the profunda. So my plan was actually to watch her and see how she did. We ended up fixing the lesion in the proximal AT, and here you can see decent flow into the pedal arch and into the plantar as well. And here's the Ibis after the sculpt balloon. And you can still see the flap. You can see a little communication into the true lumen here. So we did certainly break the flap, and the plan was to allow her to heal up here. And she actually did great. Her ABI went up to 1.0 and her toe brachial index to 0.78. And this was actually 3 months later, and she's almost completely healed at this point. This was actually a month ago. So fortunately for us, this patient did great. I'm going to actually continue monitoring that common femoral artery to make sure it does heal up nicely with duplex. Case 2 presentation, 75-year-old gentleman with ischemic cardiomyopathy, hypertension, dyslipidemia, COPD, and a 2 to 3 pack history of smoking, presents for rest pain and discoloration of the first digit. Here you can see his preceding ABI was 0.42 on the left with a toe brachial index of 0.36. And you can see the digit waveform is completely flat on the PVR. In terms of his angiogram, you can see there's a cap in the proximal external iliac artery with reconstitution in the very distal part of the common femoral artery. So in this case, I actually took a bilateral approach. Here you can see our retrograde actually exited the common femoral pretty rapidly. So I ended up turning back to my antigrade wire. These videos, just FYI, are actually hastened to make them faster. So we obviously do a little more careful wiring when we are working, especially in the iliacs. So we approached from the retrograde again, and clearly this wire was not in the correct location. Luckily, when we turned back to the antigrade, we were able to track the subintimal space further down. And ultimately, I was able to re-enter into the true lumen using a stick and swap kind of technique, using a Connect 250T. Here's the stiff wire puncturing into the true lumen, and we confirm true lumen access with distal injection using the Navicross. At this point, you can see how far away these two wire systems are. So I decided to perform Ibis. Here you can see we're pulling back from the profunda. And here's the common femoral artery. And you can still see some flow. So I know for sure that we're in the true lumen in the common femoral artery. And here you can start seeing that we're actually inside the subintimal space, as you can see the compression from the true lumen here. And I actually used Ibis to size our common femoral artery to decide how large of a stent we needed, at least distally. We performed gentle balloon angioplasty initially, and then ultimately deployed a 8.0 self-expanding stent proximally, and then a 7.0 drug-eluting stent into the common femoral in overlap. And there were two areas that looked like they were a little bit underexpanded. At this point, I chose not to do shockwave, but in retrospect, this might have been a good case for shockwave. You can still appreciate some of the underexpansion. And here you can see the areas that remain a little bit underexpanded, but still good antigrade flow. And he had a mid-SFA moderate lesion, as well as some residual stenosis in the tibial arteries. After his intervention, his ABI did improve to 0.72. His rest pain is gone. His toe brachial index remains quite low though. So this story is to be continued. I'm actually bringing him back for the remainder of the lesions to be fixed. For his toe is still a little purplish at this point. So a lot of talk about subintimal versus intimal crossing during this conference. So just a quick review on CTO and interventions in the subintimal space in the iliacs. This was published back in 2020 by Aaron Armstrong's group, looking at the literature evaluating subintimal angioplasty in the iliac system with or without reentry device. So even if you cross subintimally, the success rate is actually quite high with or without a reentry device. Complication rates can be relatively low. The complication rates that were investigated here included dissections, perforations, embolization, and other minor complications. 1-year patency ranged quite widely in these studies, as low as 51% and as high as 97%. Looking at specifically the femoropopliteal segment, then this is from our Japanese colleagues using Ibis interrogation of subintimal versus intimal crossing. And what you can see here is that even if we cross subintimally and treat subintimally, the outcomes overall, including restenosis, all-cause mortality, amputation rates are essentially equal between subintimal versus intraluminal approach. So in conclusion, iliofemoral CTO crossing can be complex and require versatility in technique. Intravascular imaging is augmentative, especially if there's a diagnostic dilemma. Findings suggest there's improved outcomes with routine use of intravascular imaging remains underutilized tremendously in endovascular interventions. Subintimal crossing have comparable results to interval crossing and iliofemoral CTOs. Thank you.
June, thank you so much. What a great night, and what a extensive, technical, kind of a toolbox for us to use for, iliacs, SFAs, and below the knee lesions, including the imaging guidance. We are past the hour, but I feel like we need to have a little bit of discussion. So with Dr. Banerjee's permission, I'm going to go over by 5-6 minutes, and your guys' permission, obviously, you're the ones who are going to answer the questions. Let's ask at least one question per person so that we get a little bit of a discussion. So Peter, I'm going to start with you. Ask one question. More and more, maybe I'm getting gray hair and getting old, I don't know what it is, but I believe that, some of these aortoiliacs are better off with hybrid approach. June showed a couple iliac cases, where the common femoral was involved. You showed a couple nice cases. What are your thoughts about, working together, and, kind of the hybrid approach of common femoral profundoplasty and arterectomy with the reconstruction of the iliacs and stuff like that?
Yeah, I think that's a terrific question. And in general, the patients that I think are probably prime candidates for a hybrid approach are the ones, in fact, that you just touched on. Those patients who have complex common femoral bifurcation disease, particularly if it's extensively calcified, and if it's also a CTO. I think those patients probably do better in the long term with a surgical approach to treat their calcific common femoral bifurcation disease, and then obviously the rest of the iliacs can be dealt with using stents. Now, if it's not a total occlusion, we've actually had cases where we've done stage intervention where we have used very successfully combinations of either orbital or plaque decision atherectomy followed by intravascular lithotripsy followed by drug-coated balloon, and have had some really excellent results. We actually published a paper where we were able to, using a combination of atherectomy and DCB, had a 92% one-year primary patency rate for these complex calcified CFA lesions. So either at the same time or in a staged fashion, if the patient is not, for whatever reason, a good candidate for an open approach to their CFA bifurcation disease, then a combination atherectomy, shockwave, DCB approach seems to be a very viable alternative. The other comment I would make is that although, traditionally the common femoral has always been taboo to put a stent there, there is some data now between the VMI study from Koondelus and then Jan Gufik's TICO study showing that out to 2 years, that there was no really significant difference between the surgical groups and the endo groups. And in fact, the endo group had less comorbidities and a shorter length of stay. So in select cases, I think it's okay to stent the common femoral if you have to. In general, I like to use the Supera stent because it's very fracture resistant, has a lot of radial resistive force. And the one advantage of the Supera over other self-expanding stents is that you can go back and stick a sheath in a Supera stent if you need to access that common femoral at a later date. And now that we finally have the 7 and 7.5 millimeter Supera stents in the US, that's giving us a lot more options.
Can you, since you touch on that, and I know we are out of time, but this is important. One of the fears, even for me, to be honest with you, done quite a few Superas in my career, is the concern of the extension of the Supera into the iliacs. If you're coming from the top, how are you doing that And are you using shorter superas when you're stenting the common femoral? How do you assure that? I mean, if you're coming retrograde, I think it's okay, because when you extend into the SFA. But if you're coming from the top and you're trying to just stent the common femoral, and you have give us some advice as to the length of the superas used for common femoral, and how do you prevent it from potentially expanding? Sometimes difficult to deploy that stent, and it can elongate into the iliacs. Next thing you know is in the aorta. So a little bit of advice, if you can.
Yeah. In general, if I have to put a stent in the common femoral, I try to put a short one, and it's super important to avoid elongation, to be very, very aggressive about vessel prep. So if you're going to put in a 7.0 supera, you've got to make sure that you pre-treat with at least a 7.0, if not a 7.5 balloon. I learned that lesson from Andre Schmidt and Dirk Scheiner a long time ago, to avoid elongation. Vessel prep is super important, and go very, very slowly, keep a little bit of negative tension, and use a short length, typically a 40. And then once you're at or above the inguinal ligament, then I just use conventional self-expanding stents after that.
Right. And I would say the one other comment I would make is that, don't be afraid to stack. If you need to stack. It's better to stack than to elongate, obviously. So yep. I think your advice about vessel preparation, you cannot overemphasize that. Anytime you want to use supera, anything, but supera especially, because of the elongation risk and invagination and all those things. Matt, thank you, Peter. Matt, I was going to ask you one question related to, and Subhash, chime in anytime you want, but let me ask this question from Matt. Can you describe the comment of hibernating artery? I mean, it's like every week in the lab, I'm quizzing my fellows, I'm challenging them. Do you think this is open or closed? And then when we get there and we take a picture, we are dumbfounded how many of these arteries are open. And so what is a hibernating artery, and what do you do to make sure that you are finding the right reconstitution to get a better understanding of the CTO length and what the reconstitution is?
Yeah, I mean, it just comes down to the fundamentals of being a great interventionalist, is you need to be a great imager. And I think it's really hard to look at a lesion on a CTA and decide if it's going to be crossable or not. And even if you do an antigrade injection, you have a very long chronic total occlusion. It can be very difficult to decide what might be possible. And I think that's when the use of external ultrasound, as well as Ibis, and to the point that June made about using Ibis liberally, I think that's where you become a little more sophisticated in seeing what's truly occluded and what's patent but just not filling well. I use a lot of retrograde angiography in my practice to kind of help shorten the CTO, so to speak, and kind of create a base of operations that's more manageable. So I really enjoy that part of doing these procedures, because you kind of create something out of nothing, it seems, but it's not quite so bad once you can confirm with great angiography what you're dealing with.
Mehdi, I want to add one comment. I actually really like June's case, where a no-nub SFA CTO was approached retrograde. I completely agree. I just have a suggestion, and maybe June will try it, that I think where you make the connection between the antigrade and retrograde devices and wires, that zone of operation could be moved further down. So a good strategy in those situations is to use external transcutaneous ultrasound to penetrate the ambiguous gap of the SFA, and at least make a minimal headway, if not lot, into the SFA and not in the common femoral. That way, you have a slightly lower chance of having a dissection. Nobody can control it, but I have found, and of course we have reported it, the transcutaneous approach of imaging, a very healthy tool. I've seen Mehdi do it in various locations. However, I think that would be a good strategy, and that can avoid some of these needs of stenting across areas that are difficult to manage sometimes. And I think you did a wonderful job of combining angiography and imaging in that case.
Yeah, I agree. External ultrasound certainly has its benefits, especially in situations where it's a little bit ambiguous as to the proximal cap. I think there's some limitations in Ohio patients because of the size.
Yes, yes, of course.
But this lady was actually a little bit on the larger side.
Especially in Ohio, huh? Especially in Ohio.
Yes.
Manas, as a Mehdi, ask Sherling your question because I am too biased.
I was going to ask you a question. If you let me ask you a question, I'm going to ask you a question. Sherling, you said something, that I thought it was critical, honestly, and I loved, hearing it from you. And maybe you can discuss a little bit more. And I think a lot of folks get into trouble. And that's the idea that the wire that you use to cross in the coronaries, we learned that in the coronaries. So for us, this is like I hope Peter and Subhash and Matt, and June agree with me. The wire unless you're working with a workhorse wire, if you're using a hydrophilic wire, jacketed wire, CTO wires, when you cross, we always you got to go to the workhorse, because while you're doing your intervention, you can get distracted and you don't want to cause a perforation. And I can tell you, even myself, I've been burned a couple of times with compartment because I was too lazy to switch to the workhorse wire. Can you comment a little bit more about that? Because I think that that's such a important point that sometimes we get lazy or try to save a few dollars, and I think cost us a lot of harm down the line.
Yeah, I think this is something that we always harp on. We always tell our residents and fellows, you don't, if you cross with the glide advantage, everyone wants to just use the glide advantage as their wire because it's a good wire, except for that hydrophilic tip. And then the next thing you know, and I've done this too, the tip is out of your field and it's in some tiny little perforator. And then you have a extravasation in the calf. And so it always leads to more trouble. So I think, I mention it because we always tell them, although I'm probably as bad as everyone else in trying to skip the steps, you really have to try to switch over to a more benign wire, because these crossing wires are good crossing wires for a reason. They go through anything, including outside of the vessel. So it's just something that we just have to keep in mind, to switch over to a more a working wire or a more benign wire when you're doing your intervention.
Well, thank you so much. I'm Subhash, if you have any parting questions, anything else you want to add, I feel like we are at 10:15 and
we're good. I think
this
wonderful. Go ahead, you go ahead.
No, listen, I just wanted to say thank you to our panelists and our speakers. Obviously, the cases, the complexity, the technical experience that you bring to these webinars are invaluable. And, your selflessness to come at this time of the night to share your ideas, your knowledge with us and with, folks that are sharing their time with us, our audience, is really remarkable. And I'm so grateful for your time. Thank you so much. Want to thank also our audience. At one point, we had over 90, audience members kind of learning, and hopefully everybody got something out of this. I learned a lot. Thank you so much. Have a good night, and hopefully we'll see you guys soon again on another webinar through CBI. Thank you.